So I'm the medical director of a small NGO in Italy, which is for Cure to Children. And the mission of which is to facilitate access to cure for children with severe blood disorder and cancer directly in developing countries. Of course, we have not invented this. We learned a lot from Giuseppe Masera, from St. Jude Cure for Kids, Scott Howard. And so far, so our main goal has been to provide financial and professional support for the startup of transplant centers. And we have helped in 12 transplant centers in middle-income countries in Asia, Middle East, and Africa, mostly dealing with transplantation for hemoglobinopathies. We so far approximately were involved in 800 transplants, as I said, mostly monoglobinopathy, 90% match-related donor, and 10% partially match-related donor or haploidentical transplantation done with post-transplant cyclophosphamide. These are the centers. We started actually in Pakistan, and then we moved to India, where we started in 3 cities, then Sri Lanka, Morocco, in Armenia, and also we tried to set up a transplant center in sub-Saharan Africa and Ghana. This experience was the base for a position paper by the Pediatric Disease Working Party of the European Bone Marrow Transplantation. It was published in 2021. These are all overall results. This is including everything. Haplo, matched, second transplant. You see we're in the range of 70, 80% disease-free survival. And this has a pretty long follow-up. This is the story of how our approach to hemoglobinopathy, match-related transplant evolved. We started, thanks to the experience mostly of Guido Lucarelli in Italy. Many of you don't know him, but he really made the history of transplantation for thalassemia. And we started with a combination of Tautepa, busulfan, cyclophosphamide. The reason being that we really did not want to risk rejection because, of course, we had the problem that technologically doing autologous backup cryopreservation was a bit difficult. So we prefer to risk a little bit in terms of intensity of transplant regimen. And so the rejection rate was not very high, but transplant-related mortality, 13%, was really not very acceptable. And most importantly, Tautepa, for those of you who have a bit more seniority, you may remember that Tautepa had a abrupt, huge change in price few years back. And so it became very expensive and also is temperature sensitive. So logistically, it's a bit difficult to procure Tautepa. The other reason that we switched from Tautepa to ATG is because we really want the major long-term side effect of transplantation, match-related transplantation, is really nowadays infertility. So that we really wanted to decrease, and the combination of 2 myeloablative alkylating agent most likely was going to increase infertility. While we knew that the combination of busulfan cyclophosphamide, this because it has been used for over 40 years. We know that in many children with thalassemia that have not been exposed to chemotherapy before can actually preserve fertility. Of course, we don't know in girls, even if they go into spontaneous puberty, most likely they will have precocious menopause. So that is something we need to keep in mind. But that's the main reason why we switched from Tautepa to ATG, busulfan, cyclophosphamide. And the results were probably a bit improved in terms of transplant-related mortality, but eventually rejection was higher. And so we added fludarabine, and actually we had pretty good results with fludarabine ATG bucide that became, and it's very tolerable. In children that have not received chemotherapy before, it is quite a tolerable regimen. And Busulfan, we actually use oral busulfan. We don't do levels. So, of course, we can discuss this. It's a bit not very sort of standard of care. But, and we use a total dose of 14 milligram per kilo, which is a bit less than the maximum. They consider what is the maximum tolerated dose of 16 milligram per kilo, the standard dose. And then at one point in India, ATG was no longer available. And so we said, and we were using, and who deals with haploidentical for hemoglobinopathies in this room knows that there's been a publication from Thailand using 2 cycles of sort of diluted immunotherapy, fludarabine, dexamethasone, which is very tolerable, doesn't cause any major cytopenia unless you combine it with something else like hydroxyurea. And so we said, okay, let's try to substitute ATG with 1 cycle of fludarabine dexamethasone. Here we're talking about match-related sibling transplant. And then followed by only flu, bu, and Psi, which also makes it much less expensive because you will see ATG accounts for approximately 10% of the cost of transplant in India, at least in our experience. And so with this fludarabine dexamethasone followed by flu, bu, Psi, we only done 22 patients so far, but we had no rejection, no death. So as far as we're concerned, this is probably one thing I had to add is that we excluded patients at high risk of rejection in this protocol. That is to say, brothers donating to sisters. We saw that they have a little higher risk of rejection. Of course, we can discuss why very briefly. Of course, girls are exposed to male blood donors. In India, 90% of donors are male. And so they may be sensitized to HY-associated minor histocompatibility antigen. So did we see in these countries problems related to the fact that they were a middle-income country? Not really. We didn't really have, we had maybe 1 child with tuberculosis late that actually local physicians knew how to handle it, and this child eventually did well. We maybe had 1 case of malaria. Again, was not a cause of mortality, but our main problem has been multi-drug resistant germs. That is number 1, probably number 1, 2, and 3 problem, especially in India where antibiotics are used very liberally and there's very little antibiotic stewardship. And so we try to minimize the use of antibiotics, and we essentially start with piperacillin tazobactam. And then if there is persistent fever, we will escalate to meropenem plus minus amikacin. If fever persists, what we do, we take out the central line. And many times that is enough. Otherwise, we have to escalate again to polymyxin B, to fosfomycin, tagacycline. Okay, so these are the complications. One thing I wanted to, a couple of things I want to sort of point out here is that first, we did not see a lot of, in spite of being thalassemics, having some iron overload, we only consider liver size. We don't do liver biopsies. And we have not seen a lot of veno-occlusive disease, sinusoidal obstructive syndrome. And the little we have seen, most of the time it resolves spontaneously. We cannot afford the fibrotide. And but we very rarely see mortality from sinusoidal obstructive syndrome. The other thing I wanted to point it out that I didn't say is that we use G-CSF prime bone marrow. There are several reasons to do that. Most is because, of course, we want to minimize graft-versus-host disease. The rate of chronic graft-versus-host disease is around 4%, more than mild. So it's quite unusual to have severe graft-versus-host disease. And of course, there is a price to pay, which is mixed chimerism. 1/3 of our patients will have mixed chimerism, which is okay. What we do, contrary to what most people, we have seen that actually by increasing immune suppression, we can hold mixed chimerism and try to obtain a stable situation. It may take 2-3 years sometimes of adding mycophenolate to cyclosporin, but these kids with mixed chimeras, they have a perfectly normal health-related quality of life. They have no GVHD, they're fine, and don't have any major complication. Of course, it's much less expensive to use for a longer time cyclosporin MMF than to have chronic graft-versus-host disease, just looking at the financial point of view. All these transplants were done without HEPA filtration and positive pressure, and the rate of fungal infection was very low. And the main reason is because, of course, as you know, the main factor for fungal infection is the host. The fact that we had period of profound neutropenia, probably in the 7 to 10 days range. And that really made a difference. So that the risk of fungal infection is not very different than one you would observe in a similar group of low-risk patients in more stringently air-controlled units. This is just to highlight the fact that, of course, dealing with thalassemia in India is not like dealing with thalassemia in Europe or the US. The expected life span of a thalassemic in India, even if you receive decent care. In India, chelation therapy is provided to all patients, same thing for transfusions, for all patients with thalassemia. But nevertheless, the average life expectancy is around 25 years of age. The other important factor, this is from Pakistan, we have seen that because of children before transplant get very unreliably transfused, they can go down to hemoglobin of 5 before they get transfused, even 4. And so, of course, after transplant, the hemoglobin is more stable and they grow better compared to pre-trans. So also from that point of view, it makes sense to offer bone marrow transplantation whenever you can offer it safely, of course. This is a paper that I mentioned before that is from Italy, actually it was from Sardinia, that looked at the very long-term follow-up after busulfan cyclophosphamide. And this is the reason why, and actually in this paper, they claim that the fertility was the same as the general population, which of course, it doesn't mean that there is no gonadal toxicity, but many patients with thalassemia, so have not received chemotherapy before, they get standard busulfan cyclophosphamide, many can retain fertility. And of course, health-related quality of life, especially in certain cultures, depends a lot on preservation of fertility. By the way, today, with gene therapy protocols, you have to give therapy, and maybe Leslie, you can correct me, that is probably as toxic to the gonads than with allogeneic transplantation. Problem? But more expensive, right? Okay. So again, just very briefly, when we started trying to support transplantation, we said, okay, any cost that is not supported by good evidence of impact or outcome, we're not going to support, because if you increase costs and less children access transplant, those are cost-related deaths. So we try to save money on, again, because of Italian had a pretty good experience with transplantation for thalassemia, we try to cut on hospital infection control costs, source of stem cells. Bone marrow is cheaper than peripheral blood stem cells, but we do it mostly because it's associated with less graft-versus-host disease. And of course, we try to save on drugs as much as possible, not using drugs that were not considered essential. Transplant units were quite simple. I said no HEPA filtration, no positive pressure, and bathrooms are actually outside. They were not sort of en suite. They were not directly connected to the transplant room, also because children normally don't use the bathroom, young children. And also the design was pretty simple. We did not enforce use of mask gowns, etc. And IV pumps and monitors were outside the room so that we limited nursing the nurses having to go into the transplant room, because of course drug-resistant germs are mostly carried by people that don't have time to wash their hands, and it happens. So we try to limit the trafficking of nursing inside the room as much as possible. This is the cost of a transplant, a simplified transplant unit, depending on the brickwork, but is around $100,000. This is the cost of transplant in 3 centers in India. On average, you can see that we can do it for $10,000, which is medical expenses for the whole year. Yeah, this is Lagos. So the cost, so this is a middle-income country, a lot of cars. The cost of each one of these cars is more or less the cost of a transplant. So the resources are there. The limitation of the cost model is largely restricted to low-risk transplants, of course, primarily dealing with healthy children before BMT, aggressive GVHD prophylaxis. GVHD can have a major impact on cost. Nurses' salary below average, and this is a big problem because nursing are the key people in a transplant unit, and if you cannot retain them, then you have a huge problem. So the nurses' salary is something that we really try to improve as much as we could. And of course, some tests and blood products had reduced rates because we have this network, and so we can sort of bargain prices as much as possible. We are very grateful to DKMS, who provided free high-resolution HLA typing with the buccal swab. Very easy, we can do it really all over the world for free. And of course, you have to keep in mind family support. And what happened to this transplant center in Pakistan is still doing transplant, but unfortunately, as you know, Pakistan is going through a problem in terms of inflation rate, political stability, and so they still need international donors. And it's not easy for international NGO to get money to Pakistan. So, however, they're still continuing. India, actually, all 3 centers are self-sustained. In India, it's much easier. By law in India, 2% of corporate profits have to go to socially responsible programs. And we have had no major problem in offering transplant independently of the income of families. Sri Lanka, again, unfortunately, with COVID, Sri Lanka had major problems because it's mostly based on tourism. So in Sri Lanka, we're not able to have a sustainable program. In Morocco, Armenia, the program is going on. In Accra, in Ghana, we had a problem with, we were not very lucky with the outcomes of children. And that, of course, was a major variable, but also we were not good enough to sort of win the support of the local professional community. This is something that we of course need to give a lot of importance to, and that in that case, maybe we were not good enough. Due to Children has a huge database in which there are a lot of children with blood and blood disorders and cancer. 80% have thalassemia, 8% sickle cell disease, 4,500 have been HLA typed, 1,500 approximately have a matched donor, and we have done 660 transplants out of this group. This is the pictures from Armenia. So we were able to use this database to convince doctors in Armenia that maybe you can start with a very low-risk patient with sickle cell disease from Africa. The indication is clear. They can do very, very well. And in fact, they did quite well. The idea seemed a bit crazy, but I'm very happy with our colleagues from Armenia that they sort of accepted the idea of doing children with sickle cell disease. So what have we learned? Nursing is the most important asset. Complex and expensive sterile facilities are not necessarily required, at least for low-risk transplants. In the startup phase, remote consultation can be very helpful, and with information technology, and low-risk transfer of hemoglobinopathies is probably an appropriate, I think is probably the best startup target for a transplant center. Conclusion, match-related donor transplantation for young children with hemoglobinopathies can be highly successful in Star centers in middle-income countries. Match-related donor for bone marrow, match-related bone marrow transplantation for sickle cell disease and severe thalassemia can be safely performed at a fraction of the cost in middle-income countries compared to high-income countries, and is probably a good is justified medically, ethically, and financially. This is the acknowledgements. DKMS in Germany is the first, is a very big organization who's providing a lot of help, both in terms of HLA typing, but also for financial assistance for single transplants. And of course, I want to highlight our Armenian colleagues, Karen, Mexetian, Luzin, Mane, and of course, Gevorg Tamamian, who's really been at the startup of the whole thing is really Gevorg, who connected me to this great team in Armenia. And thank you very much.